I feel very honored to present to such a large audience and happy that so many are interested. The other two speakers will address emergency measurement, and I will try to explain a bit about how to avoid that it comes to emergency measurement. And I will be talking about sudden cardiac arrest on the football pitch and what we know about that. We know a lot of things from so-called registries, and these registries simply record the number.
Tim, sorry to stop you. We can only see your first presentation slide. You just have to go on presenters mode. Yeah, at least this way we can see your slide.
And now?
No, it stays on the. Maybe try sharing it one more time. Yeah, perfect. Now it's perfect.
Okay, sorry about that. So registries tell us about the number and type of diseases that leads to sudden cardiac arrest on the pitch. And because I will soon show you a few results from these registries, let me explain a little bit about how they are run. Of course, they have the purpose to inform us about the causes of sudden cardiac arrest to learn from, and also possibly, if present, to elucidate some regional patterns. That means if sudden cardiac arrest comes from other causes in a number of countries than in other ones. The methodology is interesting because in no single country of the world there is a mandatory reporting of sudden cardiac arrest on a football pitch or in sports, in athletes. So it's always voluntary reporting what's been done, and sometimes on top of that media screening is done, and sometimes information from emergency organizations is available. So that is less than perfect and needs to be taken into account when interpreting the results. Let me start with a typical registry from Germany, and this is not football specific. It's sports specific, but not football specific. And almost 350 cases have been included. And on the right-hand side, you can easily see that the most cases occurred between 40 and 60 years of age. And from the methodological points that I've told you, you may even have a guess that this is kind of an underestimation. We are pretty sure that the cases in younger individuals are quite complete, whereas in the older ones, they may be missed because they are not in media. And interestingly, also these results are quite typical because 99% of all affected individuals were from recreational or amateur football, and 97% are males. On the left-hand side of the screen, you see that football was by far the leading sport, with other ones coming not even close. This, of course, reflects how popular football is in Germany, but it also reflects that it is a dynamic sport with a high sympathetic activation, like the runners-up. If we have a look into the cardiocirculatory strain in football, which arises from sympathetic stimulation, then we see that there are frequently heart rates up to the maximal heart rate. There is high blood pressure, and that is based on a high release of catecholamines. And this does not only happen in elite football players, but also in veterans. Have a look at this figure, which shows that during training and match play in veterans football players, almost maximal heart rates are reached. So it is not dependent on the level of play if you spend full effort or not, and the risk is also not dependent on the level of play. The registries that first led into consequences in Europe came from the US, and it is interesting that most of these data showed that hypertrophic cardiomyopathy, an inherited cardiac disease, is the leading cause of death. In the red circles, you can see that almost half of the athletes who died in this registry over 26 years died from hypertrophic cardiomyopathy or likely hypertrophic cardiomyopathy. So this was then used as a blueprint for several screening systems in Europe. I'll come back to that later. However, data from Italy on the left-hand side with arrhythmogenic right ventricular cardiomyopathy, another type of cardiomyopathy being the leading cause, and from France on the right-hand side showed a different picture. In France, there was a mix of causes with so-called electrical cardiac diseases being the leading ones. And when we have a look back into our German registry, we see on the right-hand side in the under 35-year-old athletes that 24% of the cases were from myocarditis, so inflammation of the cardiac muscle. By the way, on the left-hand side of this slide, you see that in the older ones, so in all cases put together, coronary artery disease is the leading cause. And that is the same in all registries for the older ages. That means above 35 years of age by definition. There is only one football-specific registry existing, and that's run by FIFA and UEFA. It is an online platform, and it also collects information from national registries and from FIFA Medical Centers of Excellence. On top of that, and most importantly, there is a professional media screening that is conducted. And this protocol has been published open access in the British Journal of Sports Medicine already in 2015 and is available for all of you. Also, the internet address is shown here. From this registry, we have a first publication about 617 cases, of which 142, so 23% were survived. The average age was around 35, and most of these cases were collected by press monitoring. The same pattern as before, almost 96% of all cases were in males, and only a low number of cases in elite players. If we have a close look at the younger players on the right-hand side and the older ones, or all players on the left-hand side, we can once again see that it's a mixed picture in the younger ones, whereas coronary artery disease is the leading cause in the older ones. If I may quickly summarize what we see in all these registries in different patterns dependent on the region of the world, then we have cardiomyopathies, so inborn cardiac diseases that become obvious a bit later in life. They are responsible for many cases. Then we have the so-called ion channelopathies, the so-called electrical heart diseases that are relevant. We also have coronary artery disease, so narrowing of the coronary arteries, and we have anomalies of the coronary artery course, particularly in the younger ones. And then we have two entities of disease that cannot be found during screening examinations. That is myocarditis, because it follows an infection, and commotio cordis, because it's a blow to the chest that leads to cardiac arrest, and this can hardly be known before it has happened for the first time. Screening examinations are considered the main tool to avoid these cases of sudden cardiac arrest and sudden cardiac death, since the groundbreaking investigation from Domenico Corrado from Italy from 2006, he showed clearly that the solid line the solid line in this figure shows a decrease in all cases of screened Italian athletes after the introduction of screening examinations in the early 80s, whereas the unscreened non-athletes, this is the dotted line, they are on the same level throughout the period of investigation. And this has been reached by a very simple set of examinations, only medical history, physical examination, and a resting ECG. And only if this combination of examinations led to dubious findings, then follow-up was conducted. Based on this, the European Society of Cardiology, ESC, has recommended exactly that Italian program to be carried out in all elite and competitive athletes. However, in the US, only the medical history and physical examination is the current recommendation. And the reason is mainly the lacking specificity of the resting ECG. Because if the resting ECG is not specific enough, it has too many false positives, and these follow-up examinations are particularly costly in the US, where an echocardiography, which is the most frequent follow-up examination, costs about 4 to 5 times as much as in Europe. Fortunately, the Seattle criteria developed by Jonathan Dresner have improved that situation by far, and the specificity of the resting ECG has been improved. I think everybody who is doing screening examination should have these ECG criteria on its desk, on his or her desk. Well, of course, in certain countries, in certain associations, and for international organizations, screening recommendations do not automatically follow only this Europe-wide recommendation, but are varied. So, for example, in Germany, we have a relative sophisticated system with a maximum version only for the male Bundesliga and second Bundesliga, whereas the minimum recommendations from ESC are still used as a guideline for the lower leagues and the young ones. Whereas for the female leagues, where the risk is lower, and for some of the younger leagues, the medium version B has eliminated the most expensive examinations. In UEFA, it's a bit different because UEFA firstly has to cover only or mainly high-level competitions, but on the other hand side, 55 member nations have to be covered, and everybody has to be able to conduct these examinations. So there is a set of examinations that is mandatory in all UEFA competitions, whereas other examinations are only mandatory in a few competitions. So overall, one can say that on the UEFA level, the ESC recommendations with history, physical examination, and a resting ECG are held as mandatory, whereas some other examinations, like an echocardiography, which is conducted biannually, is only reserved for some competitions. With this short introduction into how to avoid sudden cardiac arrest on the pitch, I'd like to hand over back to Evert, and thank you very much for your attention.